Sandra Kowalski was 58 years old and had never had a heart problem. Normal blood pressure, cholesterol within parameters, stable weight. She didn't smoke. She walked 4 times a week. She was the type of patient the general practitioner presented as an example during consultations with other patients. The type who goes to the annual checkup, receives the results, hears everything is great, and leaves believing that it really is. Sandra had been drinking coffee for 20 years. Not the coffee most people drink filtered from an automatic machine, quickly brewed. Sandra drank French press coffee. Immersion coffee. French press, twice a day, in the morning and after lunch, with the darkest beans she could find, the coffee that the barista at her favorite shop in Minneapolis described as full body, long persistence. She had gifted 3 people with French press coffee makers in the last 5 years. She had converted her husband. She had convinced her sister. In March 2023, Sandra went for a routine chest CT scan ordered because of a family history of pulmonary nodules. The exam didn't find any nodules. It found something else. The radiologist called Sandra's doctor 2 hours after the exam. Sandra's coronary calcium score, the index that measures the calcification of the arteries that supply the heart, was 847. For a 58-year-old woman with no cardiovascular history, no hypertension, no smoking, no diabetes, the expected score was below 100. Above 400 is already considered a severe cardiovascular risk. Sandra had 847. Sandra's coronary arteries were calcified to a degree that put her at risk of an acute cardiac event comparable to that of a 40-year-old smoker with untreated chronic hypertension. The cardiologist who saw her the following week made the standard list of risk factors. Cholesterol, normal. Blood pressure, normal. Smoking, never. Diabetes, no. Sedentary lifestyle, no. Family history, no documented heart disease in parents. Then he asked about coffee. Sandra said she had been drinking French press for 20 years. The cardiologist was quiet for a second. Coffee is not dangerous. That's the first thing that needs to be said, because what comes next depends on a distinction that most people have never received, and that most primary care physicians don't mention, because coffee is so deeply embedded in the culture that questioning its preparation method seems absurd. Filtered coffee brewed through filter paper, in an automatic machine, by any method that makes the liquid pass through a fibrous barrier before being consumed as safe from a cardiovascular standpoint, according to decades of epidemiological literature. The filter retains lipid compounds naturally present in coffee called diterpenes, specifically cafestol and kawel, which would be absorbed by the digestive tract if they reach the intestine. Unfiltered coffee, French press, boiled coffee, Turkish coffee, espresso without filter paper, immersion coffee in any form does not pass through a fibrous barrier. The diterpenes reach the intestine intact. They are absorbed. And in the body, cafestol and kawel inhibit liver receptors responsible for LDL cholesterol metabolism, producing a dose-dependent, progressive, and completely invisible increase in circulating LDL in those who are not being specifically monitored for this. The increase in LDL produced by chronic consumption of unfiltered coffee is not dramatic in a single test. It is cumulative. It is the type of increase that, over 20 years of daily consumption of 2 cups of French press coffee, produces a difference of 20 to 30 milligrams per deciliter in average LDL, enough, according to data published in the European Journal of Clinical Nutrition in 2001 by researcher Martinci Ergert of Wageningen University, to increase cardiovascular risk by 10% to 15% over decades. 10 to 15% from 1 cup of coffee, twice a day, for 20 years. Sandra's LDL levels in routine exams had always been between 118 and 134 milligrams per deciliter, within the range considered normal, but consistently at the upper limit of that range. Never alarming enough for intervention, never high enough for any doctor to ask what might be chronically and imperceptibly elevating it. No one had asked about her coffee brewing method, because coffee brewing method is not included in any routine cardiovascular assessment questionnaire in the United States. What Scandinavian epidemiology, the region of the world with the highest historical consumption of boiled, unfiltered coffee, has documented about the relationship between coffee brewing method and fatal cardiovascular events, is the most disturbing data, because it was collected over decades and reported in high-quality scientific publications that have remained completely absent from American doctors' office conversations. In 2020, Dag Thel and colleagues from the University of Oslo published in the European Journal of Preventive Cardiology the results of a prospective study with 508,747 Norwegians followed for an average period of 20 years. The data showed that consumers of boiled coffee, the Scandinavian equivalent of the French press, an unfiltered brewing method, had 12% higher cardiovascular mortality than non-consumers, even after controlling for all conventional risk factors. Consumers of filtered coffee, on the other hand, had slightly lower cardiovascular mortality than non-consumers, consistent with the cardioprotective effects of other coffee components when diterpenes are removed. 500,000 people, 20 years of follow-up. The difference between one preparation method and another was measurable in mortality. And here is the mechanism that transforms epidemiological data into Sandra's personal biological process. Calcifying is the most potent LDL-raising dietary compound identified to date in foods widely consumed by Western populations. In doses equivalent to those present in 2 daily cups of French press, Calcifying raises LDL by an average of 6 to 10 milligrams per deciliter over 6 weeks of continuous consumption. This number partially normalizes when consumption ceases, but the arterial calcification accumulated over decades of exposure does not regress as easily. Arterial calcification, the process by which calcium deposits form on the walls of the coronary arteries in response to chronic inflammation and the accumulation of oxidized LDL in the arterial wall, is irreversible in its advanced stages. Calcifying atherosclerotic plaque doesn't disappear with a change in habits. It can be stabilized. Its progression can be slowed. But Sandra's 847 coronary calcium score isn't going to drop below 100. What's calcified is calcified. Sandra had been drinking French press for 20 years without knowing she was doing it. Because no one had told her that the method of brewing coffee mattered biologically. Because no one had made that distinction in the only conversation where she could have changed her habit before the accumulated damage reached the threshold documented as severe cardiovascular risk. In 2019, Mayo Clinic cardiologist Dr. Francisco Lopez Jimenez, one of the leading American experts in cardiovascular health and lifestyle, published an analysis in the Mayo Clinic proceedings documenting that the recommendation regarding coffee brewing method is absent from virtually all cardiovascular risk assessment questionnaires used in primary care in the United States despite Scandinavian epidemiological evidence being available for over 30 years. The documented reason for this absence is that the evidence, while robust in population epidemiology, has not been tested in large randomized clinical trials specifically for the American population. And in the absence of an RCT, most American primary care protocols do not systematically incorporate the recommendation. What this means in practical terms is that American family doctors ask questions about smoking, sedentary lifestyle, diet, alcohol, family history, and medication use, and do not ask questions about coffee brewing method, because the form doesn't ask for it, because the protocol doesn't include it, because the existing evidence is considered insufficient to change official guidelines, while it remains sufficient to calcify coronary arteries over decades of unguided consumption. Sandra had gone through 12 general practitioner visits and 3 preventive cardiovascular exams in 20 years. No doctor had ever asked if she used filter paper. Sandra's paradox wasn't about the coffee. The evidence for the cardiovascular health benefits of filtered coffee is solid antioxidants, anti-inflammatory compounds, an association with a lower risk of type 2 diabetes and Parkinson's disease. Sandra could have drunk coffee for 20 years with all these benefits and without the accumulation of diterpenes that calcified her arteries. The instinct to seek quality, to choose the brewing method considered more artisanal, more complete, closer to the original coffee experience, the instinct that had led Sandra to the French press, to the full-bodied coffee, to the morning ritual with the French press created chronic exposure to the only compounds in coffee that have a documented adverse cardiovascular effect. The cardiologist had said during the consultation, "You could continue drinking coffee, you would just need to switch to using a paper filter." One sentence, one change of method, 0 cost, 0 sacrifice in habit. That no one had said in the previous 20 years. What American medicine learned from Sandra Kowalski, from the Norwegian study of 500,000 participants, from Ergert's research in Wageningen, and from decades of Scandinavian epidemiology that document this distinction is that the information exists, it is robust, and it is systematically absent from the consultation room conversations where it could make a difference before the damage becomes irreversible. What Sandra never received was the conversation that should have happened at the first consultation when a doctor learned that she drank coffee. One question: how do you prepare it? With a filter or without a filter? French press or machine? This question does not exist in the standard American cardiovascular assessment questionnaire, not because the evidence does not exist, because the protocol has not yet incorporated it. Sandra's coronary calcium score is 847. It is treatable. It is monitorable. The progression can be slowed with statins, with a change in coffee preparation method, with the protocol that finally exists now that the damage is already documented in a CT scan that was ordered to look for pulmonary nodules that were not there. The calcification that's there won't go away. The filter cost pennies. The arteries cost 20 years. The difference between coffee that protects the heart and coffee that calcifies arteries over decades is not the amount of coffee, not the origin of the beans, not the roasting, and not the price. It is the presence or absence of a paper filter between the coffee and the cup. Paper filters retain cafestol and Ca-wol. Without a filter, they reach the intestine. In the intestine, they raise LDL, chronically elevated LDL, even at subtherapeutic doses that do not trigger alarms in routine examinations, calcifies arteries over years. If you drink French press, Turkish coffee, boiled coffee, immersion coffee, or espresso without a paper filter, and are over 40 years old, ask your doctor for a coronary calcium score. The test is non-invasive, exposes you to a minimal dose of radiation, and costs between $75 and $150 at American imaging centers, often not covered by insurance but accessible as a direct payment. The result tells you in precise numbers the current state of your coronary arteries, without waiting for the first cardiac event to discover what has been happening inside the vessels for years. And if you haven't yet experienced Sandra's damage, the change is simpler than any other cardiovascular intervention a doctor can recommend. Change the brewing method. Place a paper filter between the grounds in your cup. Continue drinking the coffee you love, with all the benefits that coffee offers, without the one component that your arteries cannot eliminate as easily as they eliminate the rest. One piece of paper, cents per cup, 20 years of difference. But unfiltered coffee is not the only dietary habit deeply ingrained in American culture that produces cumulative cardiovascular damage through a specific biochemical mechanism that medicine rarely explicitly names in doctors' office conversations. In the next video, partially hydrogenated vegetable oils that are still present in American processed products under names that consumers don't recognize as trans fat, and what they continue to do to the cardiovascular cell membranes of those who consume them without knowing they are still consuming them.